Welcome back. Hi, everyone. Welcome back. Thank you again for joining us today for our annual Institute for Science and Policy Symposium. This year's theme is the future of science policy, and I am thrilled for today's panel that we have here with our very esteemed guest. We'll be talking about the future of public health. My name is Kristen Uhlenbrock. I'm the Executive Director of the Institute for Science and Policy, and I'm just really grateful to be able to listen to today's conversation. I know I'm going to hear a lot of thought-provoking ideas and discussion as we talk about the future of public health. I'm not going to take much of your time. I just wanted to welcome you all as our audience, remind you to engage in the chat with any questions that you have. We'll kind of pass those along to our panelists and let them incorporate them into the discussion as they go about, and we'll do our best to try to incorporate as many of those questions as we can. We do have about an hour and a half for today's conversation, so we have plenty of time to cover a lot of ground, although this is a pretty big topic. So when we talk about the future of public health today, we're going to be talking about some of those emerging risks, as well as social inequities as it affects health outcomes for many individuals. We're going to be able to spend time drawing on some past lessons. You can't talk about the future without thinking about our past and our history and where we are today. And what are those systems that we need to build and strengthen our institutions, particularly the institution of public health into the future, as it relates to trust, as it relates to the depoliticization of science, and as a way to just kind of build those bridges to make sure everyone has the health outcomes that we want. So I'm really thrilled to have three very great guests. I have had the chance to work with all three of these people in various ways in the past, and it's nice to bring them all together. So we have Dr. Georges Benjamin. He currently serves as the Executive Director of the American Public Health Association. He's been there since 2002. He has been leading the association's push to make America the healthy. Prior to joining APHA, he served as the Secretary of the Maryland Department of Health and Mental Hygiene. He has many publications and authorships. He also has a book that I felt was kind of relevant to today's conversation, Public Health Under Siege, Improving Policy in Turbulent Times. Thank you for being with us today. Georges, how are you?
Thanks for having me. I'm excited about being here.
Thanks for being here. We also have Dr. Sandro Galea. Sandro is the Dean and the Robert A. Knox Professor at Boston University School of Public Health. He has been named an epidemiology innovator by Time. He's a top voice in healthcare by LinkedIn. He's one of the more cited social scientists in the public health space that we've seen. You may have seen him in many either TED Talks. He's often quoted in the major news outlets as well. He is a native of Malta, and I didn't know this, Sandro, from the last time we spoke. And he has served as a field physician with Doctors Without Borders. He also has a new book. Last time I think I chatted with you, you had a different book during our pandemic, but one of your newer books that you have is The Turning Point, Reflections on a Pandemic. It came out this year. Thank you for joining us today. How are you been?
I'm well, Chris. Thank you for having me back. It's a pleasure to be here.
Thank you. And Cathy Bradley, Dean Cathy Bradley. She is the Dean of the Colorado School of Public Health, who we have been a longtime partner with. And I've recently gotten to work with her and get to know her more as well. She also serves as the Deputy Director for the University of Colorado Cancer Center. Dr. Bradley, she is a health economist and also holds the Paul A. Bunn Jr. Endowed Chair for Cancer Research, which is a lot of her background as well in her research. She serves on many boards, many committees, including the national committees, among others. She is both an expert in today's conversation, and she's also going to be our guide and lead us through today's conversation. Thank you, Cathy, for joining us today.
Thank you, Kristen. Thanks for that introduction, and thank you for hosting this panel. Such an opportune time to discuss the topic of public health and where we're going.
Why don't I pass this off to you, and you'll have a wonderful conversation. Enjoy, everyone.
Fantastic. Thank you. Okay, let's think about the elephant in the room, perhaps, that with President-elect Trump coming into office again, and some rather interesting picks for leadership in health agencies. Would you all like to just reflect on what that could mean for public health and where we might be going?
Sure, let me start. Obviously, anytime you get a new administration, they change people on the deck chairs. And those people bring their ideas to the table. And then, of course, the administration as a whole brings its perspective to the table. Um, Obviously, no one's been confirmed yet, and that they're going to go through that process. And as you know, they're picking some pretty unusual people with backgrounds that have not historically had experience in government or in public health. So I do think there's going to be a huge learning curve for all of them. But I do believe that one of the things that they've clearly articulated is that they want to now pivot to addressing chronic diseases as a core activity, which is good. Somewhere around 6 of every 10 Americans have a chronic disease, at least one chronic disease, and probably 4 of 10 Americans may have more than one. So I think the challenge we have with that is that chronic diseases are a big deal. They're, of course, part of the leading causes of death. And so I think as we move to this new administration, we're all going to not abandon infectious disease, but try to figure this as an opportunity for us to move a chronic disease agenda forward in the nation.
Sandro, your thoughts to add?
Yeah, I think I look at this in 3 ways. Number one is what impact could I echo what George has said about, of course, new administration, new leadership. I think one has to respect that. I think there are 3 elements. Number one is what will the actions of new administration do to change the structures that shape health? We know that health is driven by the world around us, by our incomes, our education, quality of our neighborhood. So the first question is, it's a bigger question, which is what impacts are the administration's actions going to have on the world around us that is principally responsible for health? The second question is, what impact will the administration's actions have on the tools and processes and mechanics of public health? And that is, now we're dealing with federal agencies, state agencies, local agencies. And the third question is, what impact will new administration have on a culture of trust and a culture that unites rather than divides, which we know ultimately underpins a lot of the social capital that drives health. So I think we have to look at it in those 3 ways. And of course, very hard to say what's going to happen in new administration. And I think we need to approach it with a very much an open mind and a willingness to listen to new ideas and a humility to recognize that there might be very different ways of doing things that actually might still be good ways of doing things. Having said that, we do have this administration's prior iteration, 2016, to lean on. And there were a number of things that happened in 2016 that I think portended disinvestment in the structures that generate health, in the actual mechanics of the actions of public health, and in approaches that were much more divisive than they were uniting. And I think all 3 of those we saw as threatening health. Of course, the last time this administration was in power, 2016 to 2020, it was also compounded by the COVID pandemic, which made things even more complicated. So it is a little bit murkier to get a clear picture of actually what that period was like. But I do think that we have precedent to pay attention to, and I think it helps us to organize our thoughts around these 3 areas and how administration action can affect us in those 3 areas. And by us, I mean all of us as people who want to be healthy.
Yeah, absolutely. And if I may add a 4th area, I think that we observed last time was a lot of people left, a lot of very experienced people within the government didn't adjust to the new administration and they left. And there was a lot of experience that was drained out of these agencies that we've come to trust and just who knew how to get things done. How might that component as well figure into it? And what can we do as public health educators, professionals, to be able to counterbalance some of that?
Well, I think certainly one thing we can do is try to encourage people to stay. Now, we're part of that exodus was, of course, also because people were kind of baby boomers were kind of aging out, and that's going to continue. We should anticipate that's going to continue. COVID obviously had a large burnout factor as well, so that exacerbated the number of people that are left. And I think as we think about how we think about all the people we're training, I do think it's going to be important for us to give them the a different set of skills as they're going into new public health agencies. Better communication skills, particularly around risk communication, better political skills. And what I mean by that is using political science and different leadership skills in order to, manage people that you don't control, so that, public health has always been able to manage things by influence, but that has historically been those of us at the top. And now we need to make sure that our entire workforce is empowered with those skills as well. Because quite often now they're having to engage people differently than we had to in the past. And the truth of the matter is, they're not only having to communicate, through the press release and news services, but now they've got to communicate, frankly, 24 hours a day, 7 days a week in cyberspace, which is a very, very different mode of communication. And as I told us old folks, are not as good at it as our younger staff members.
Yeah, I agree completely with what George said. I think there is a danger in a moment like this of for people who are working towards improving the health of the public to withdraw. And I think there's also a danger of people who work towards the health of the public seeing themselves as being only in opposition to what an incoming administration might do. I think those are both mistakes. I think, first of all, we need good people who are committed to the health of the public to keep doing what they're doing and to keep advancing the issues of public health. I think we need people who understand these challenges that we actually are discussing here. But I think we also need, at this point in history, at 2024, 2025, to reckon with the long tail consequences of past 10 years of national divisions that exacerbated deeply by COVID, to learn how public health can go back to being what it should be, which is a unifying force, a force that unifies based on a aspirational goal that frankly is shared by everybody in the population, that we are all healthier and that our children are all healthier. So I do think this is a moment that requires good people of good conscience in public health to redouble our efforts, not to withdraw and exit, but to actually say the world needs public health more than ever. And we should remember always, I think, that poor health is directly linked to people voting for leaders who are willing to rip up the playbook. And there is a very tight linkage between poor health and upheavals politically, like what we're seeing happen in this country, we'll see happening in Europe. So improving health is better for societies for the sake of improving health, but also for stability of political systems. So all of this, I think, says that we need people who care about health to do more, not less.
So, and all interesting comments. And George, something that you said kind of triggered some thoughts, which was historically public health people have been communicating higher up. And then you went on to say, well, now we need to communicate everywhere, including in the cyber world, so that we, as Sandro said, kind of embrace a broader community to understand that public health is for everyone. Do you have examples or strategies of where that's worked well? And I'm thinking about our students, right? Because one of the things that we want to make sure we don't do is discourage the young, bright minds from coming into our field by all of us kind of being worried and retreating, and to see this exodus. We want to be the ones as leaders of the field to be able to say, no, we want you to stay. Here's some examples of how it can really work.
Yeah, let me start by saying, let's talk about the traditional community meeting. We always pride ourselves that we engage communities, but the historical community meeting has been, we would take our group of our staff, we'd work with someone who was trusted in the community. We would go into a school or a YMCA or a church, and we'd go them and we'd give them our pitch. We'd go there and we would speak to them, and then we would ask questions. And I would argue that what we have learned works better, particularly in a time where communities are divisive and where people don't have the trust. Let's reverse that conversation. You go in and say, we're here. Tell us what your needs are. Tell us what your problems are. Now, you may have the idea of your program that you want to you want to get them to participate in, and you have your ideas on how you can help them. But I think we should listen more, and then maybe not even give the pitch that night. Go home, come back later and say, okay, we've heard you. Here's our thoughts, and then have a conversation with them versus giving them the lecture and then the Q&A. And I think that's a skill set that we might want to do. The other thing is pre-bunking that conversation by engaging in the community, using community health workers that go in and kind of lay the groundwork for that conversation. I remember when I was the Secretary of Health for the state of Maryland, and I had to go into one of the rural communities on an island. And some of you may know I was the first African American Secretary of Health in the state of Maryland. And so there have been some real conflicts around preparation of foods on that island. Long story, not really worth getting into. But the point was my staff went in to make sure that the community knew that I was coming in to listen to them and not to bring the hammer down on that community. And I spent some time with the legislators that were involved with that jurisdiction. I spent some time with community leaders. And of course, in Maryland, the political divide is the bridge. People that live on one side of the Chesapeake Bay are viewed differently than people live on the other side of the Chesapeake Bay. And of course, I live on the west side of the bay. So I'm a West Bayer, African American, coming into a rural, fundamentally white, blue collar community. And so I was an outsider by all kinds of measures. And the way we broached that was by lay the groundwork for my coming in. And then we came in, we had lunch, we talked, I listened to them, and then I promised to come back with some solutions to the problems that they gave me. And the truth of the matter is we brought them, frankly, the solutions that we were going to give them to begin with, but they were altered a great deal by what we heard from them and the way we presented them and the way we measured the outcomes and success of what we wanted to do.
Yeah, I actually don't have much to add to that other than to elevate, underline, and boldface George's comment and experience. I've said this in some of my writing and speaking that when one commits to public health, one commits to caring about the health of the whole public, not the health of half the public. And it is difficult to remember that, and particularly difficult to remember that our commitment is equal to the health of the public we may disagree with as it is to the health of the public that we do agree with. And if I may be so bold as to suggest that we, and by we I mean those of us who are in public health, be it in academia and practice and advocacy, have not been as good as we should be in the past 10 years in very divisive times at being clear that our constituency is everybody, not just half the public. And this is the moment when we need to lead by example. And I think cross the bridge. In George's case, it's a literal bridge. In most of our cases, it's a metaphorical bridge, but to make sure we cross the bridge at all times.
Yeah, absolutely. Sandro, do you have any examples that you can give to talk about experiences where you've had and been able to do that successfully?
I think the challenge is to allow space for disagreement without allowing us to fracture and become disagreeable with one another and with others who do not necessarily like what we have to say. And the only way to do that is through careful choice of language and through persistent and insistent effort to make sure that everybody's included in our big tent. And I would start that from our very language. It's never us versus them. It's not about them. It's about us. It's always about us. It is always about us. It's always about us together. And if parts of us may say things that we find offensive, the right approach is to say, why is that being said? And how can we have the conversation to narrow those gaps? And I think you see this, I want to be clear that you see this happening in thousands of times every day by all sorts of people who work in our space. So it is, I think there has been an abiding narrative of division. And And I think that narrative does not do justice to the people who are doing this very well every day. And our job now is to flip that and make sure that the narrative is that we in public health are in the lead of uniting because our constituency is everybody.
Absolutely. Absolutely. We are here to serve everyone, regardless of race, ethnicity, how they voted, where they live, all of those things. It's everyone that we can bring to the table, and the better job we can do about explaining what public health is and the benefit that we bring, and to understand the science, the better off we all are. I think as academics, sometimes we get sucked in, right? I mean, because we're experts, you know, we write about things, we pontificate about things. And then when we hear somebody say something, our instinct is to kind of argue, right? Pick it apart. And I think you're both alluding to some techniques of saying, well, maybe it's us, you know, maybe the reason our message isn't as well received is because we haven't done the greatest job of accepting that someone actually believes something that disagrees with what we believe. And we're trained to pick things apart. And so how is it that we start this conversation without maybe going to some of our instincts? And were there lessons learned during the pandemic that we could do much better at?
So many. Let me start by saying the most important thing that we need to say anytime we open our mouth, which we should do after we've spent some time listening, is to say, this is what we know today based on the information we have today. And I may come back to you later with a different recommendation based on new knowledge that I have. And that means I've either changed my mind or I'm altering what I'm telling you, but I'm doing it for a good reason. And then when you come back, if you have to change your recommendation, remind them that you reminded them, that you told them that, you know, this is what we knew today. And then explain, this is why I'm making that recommendation. And don't do it in the usual mechanism of fire and forget. We'd love to send out press releases that state something. And then when something changes, we'd love to put out additional press release with the change without having the conversation to explain what that change meant. That happened with masks. That happened with what we understood around the efficacy, around transmission of the vaccine. And we just have to spend the time to overly communicate to people to make that happen.
Yeah, let me just build on that a second. If anybody's interested in this particular specific topic, if you go on my blog, which I call The Healthiest Goldfish, the last 2 weeks I wrote 2 pieces about this notion of false certitude, which really relates directly to what George has said, which is the challenge when we express false certitude, when we say we are 100% right. And in doing that, there are 2 challenges. Number 1 is we leave no space for us to afterwards say, actually, the facts have changed. We now know differently. And number 2 is we leave no space for you to disagree with me. Because if I'm 100% right, you're going to say, well, then if I'm going to disagree with you, it's going to be an argument. So I think communicating with due humility to recognizing that the facts change, and as the facts change, as data change, we may change our mind is number 1. Number 2 is to make sure that we communicate in such a way that it is clearly a conversation, not an imperative. And if there was ever a time to realize that a false certitude and overly dispositive way of communicating backfires, it is in the post and after COVID. Now, what's tragic about this is that we've known this from our public health science. Like, we've long known, anybody who does behavioral interventions knows, for example, that there's good data that if you do overly aggressive ads against harmful products, actually they have the opposite effect. Actually, people are more likely to embrace the harmful products. I mean, we know this. I mean, there's literature on this in tobacco. So COVID, I think, because of the fear and the urgency and the antagonism, let's be honest, of the administration, federal administration at the time, pushed us into this overly dispositive false certitude that has resulted in this lack of trust backlash that we're seeing right now.
So that fits in perfectly with a question that we just got in on the chat, where the questioner asked about how do we use personal stories, and refers actually to how the anti-vaxxers are really effective at saying, my child is autistic because of this vaccine. And they can bring these very powerful kind of emotional stories that parents are all going to be worried about. Public health has a way of being so understated, we save the world, right? On a regular basis, change the course of history and don't tell our stories. And sometimes, I'll say this from my own experience working in the cancer world, it's very effective when you show someone who was diagnosed with cancer, had a very bad prognosis, was treated with this new exciting drug, went on to get better, versus the prevention side of the story where you invest in prevention, but you don't observe the outcome. You don't see that miracle happen in front of you. How do we then incorporate personal stories, to say, well, public health had an observable outcome that saved your life in the following ways today?
Maybe let Sandro go first. I know he's done a lot of these in his books.
Well, I mean, my answer to that generally, to this kind of question, generally speaking, is I am deeply hopeful that the next generation will have better ways of doing this than our generation has had. And I don't mean that. I don't mean that glibly. I actually do think that the nature of communication has changed dramatically in the past 10 years. And as a subset of that, the nature of communication about health has changed dramatically in the past 10 years. And yes, we need to weave stories in. I see Martin Volker asked this question about stories. I agree completely. And as George has said, I've tried to weave stories into my books, but, I have not at all, for example, tried to engage in the kind of rapid fire call and response engagement of storytelling in a lot of social media platforms. There's just not something that's native to me. I'm not comfortable doing it, but there are younger scholars, activists, practitioners of public health who are much more engaged in that. And I think we need, I see Martin replying, I agree completely with Martin's comment. We need to up our game in the realm of science communication. I agree that it should be part of training of the future of public health professionals. And I also feel like with these things, sometimes I feel like there's almost an implication that everybody who's in public health needs to be very good at communicating. I'll use an example on TikTok. That's not the case. We need to make sure that some of us are. I mean, we are part of a community with intentionality. We need to make sure that we have people in our midst who know how to use that medium, which is becoming ever more important, particularly for Gen Z and Gen Alpha. And that needs to be some of us, not all of us. Collectively, we need to make sure that we're better telling the story. And to the point of science communication, I'll just say one last thing. Look, if there ever is a field that should be on the cusp of evolution and reinvention, it's health communication. And I think that we could look at negatively, but I like to look at positively. It's an exciting moment, I think, to think about how to communicate for health in the coming decade. I mean, we're here at the end of 2024. At the end of 2014, I would venture to say that none of us would have said that the next decade is going to require a complete rethink of health communication. We just did not see it. Goodness knows what we're not seeing today.
No, I think Sandro's absolutely right. And there are two things. Number one, when you're talking about an individual who's articulated a challenge with their family member and the disease, I remind myself is that I'm not the physicians as a physician, I've not seen them. I've not examined them. I've not looked at their medical record. And I'm not in a position to have a debate about the etiology of their loved one's condition. And so I acknowledge that I show the empathy that for them. I acknowledge your loved one's condition. I'm not in a position to debate because I don't know what caused the autism or other disease that you're articulating with your family member. And then sometimes I'll go and say, but here's what we know based on science today. And I'll give them the evidence as I see it. The other thing that I do is I think that we need to do a better job of articulating what we do know in the terms of case studies. So the reason that there is this abundance of stories around vaccines causing autism or lead causing intellectual disabilities or things that nutritional supplements do this or don't do this, it's because we don't have an abundance of good science to put out there. If you put the right information out there and allow people to do their own homework, they will usually come to a decision that is more likely to be based on the evidence and the science as we know it than the wrong information. People are pretty smart, but when you only have one point of view being debated, being put in front of people, and often put in front of people in terms that they can relate to, in, like we would always say, terms of where they are, that's all they're going to hear. And the fact that we've now moved into our own silo ecosystems of communication, people only hear one viewpoint. And we need to both enter that conversation as frequently as we can with the evidence that we believe is correct. I think that would be helpful.
Yeah, I agree. You know, as dean, I'm constantly saying to our school, tell our stories of success, tell it in a relatable way. But I'll tell you, one of the challenges, and this fits in well with another question we got on our chat, is it does seem at times, no matter how clear we tell the story, no matter how good the science is, if we're not trusted, you know, if they don't trust us or see us on the other side, whatever that other is, it's hard to be receptive and to see it as really good science. How is it that we restore that trust?
Yeah, well, I'll try to, the challenge with trust is the old adage, right? It's takes decades to build and moments to lose it. But the one thing that's certain is you can't really build trust in a moment of crisis. It's I've used the metaphor in some of my writing, speaking of if you're in a ship in a storm, right? And if the captain says to her crew, trust me, let's do this difficult thing. If the crew doesn't trust you in the middle of the storm, that's not going to go very far. You need to generate trust when the ship is in calm sailing and people know that you're committed to the same values, that you know what you're doing. And, at the end of the day, I tend to see trust as at the intersection of three forces. I think you need competence. People need to see competence. I think people need to see a commitment to shared values. And there needs to be the imagination and cultural will to act on what somebody who's being trustworthy is asked to do. Those are built over time. And I think we need to build them now, not during the next pandemic. I think we need to build them through an anticipated upcoming few years of adversity for the goals of public health based on the three things we said. And I think we need to demonstrate that through our actions and behaviors, through how we communicate the science, how we do science, how we include others. Now's the time, not during crisis.
I absolutely agree with that. I think that now's the time for us to get out there, have these conversations, acknowledge with people that we disagree with. But at the end of the day, most people can identify the right problem. It's the solution or the pathway to that solution that is the variance. So if you can get people to agree that, yeah, everybody ought to have a health insurance coverage so they can go see the doctor. Everybody should be, have safe, nutritious foods. Big ideas that are kind of common sense. And then you can work collaboratively to come up with the solution that, that makes sense. And again, don't go in with preconceived notions that you know exactly what they perceive and understand those solutions are.
Yeah, one of the things I see some of the members of our field doing is somewhat panicking right now about what's coming ahead, and maybe some of them are feeling this PTSD from COVID, or they're just worried about what happened last time and projecting into the future, right? They're just panicking. I think it's really important that we ourselves start to calm down, right? And so that we can sow this trust, build this trust now, because if our immediate reaction is to panic, we're probably not sending the right message in order to build this foundation of trust which is then where the foundation of science is built upon, and the values and understanding science and agreeing on what the problem is, and then the harder step of agreeing what the solution is and what the solutions work for you. I see this sort of widespread panic amongst our own profession. How do we overcome that? How do we overcome that for ourselves, for our colleagues, our future students, the people sitting around the dinner table that are saying, I was asked a question recently, are you stockpiling vaccines? And no, I mean, these kind of things though, but have crept into the conscious.
Yeah.
How do we move out of that space? Because I think it's really critical that we do so.
Well, I'm an ER doc, so I think always the first thing you do is take your own pulse into the middle of a disaster. And if you got one, you got time, and don't worry about it. And people just need to step back, take a deep breath, and solve the problem. Sandro, your thoughts?
Well, I'm also an ER doc, which is one of many reasons why Georges and I agree on many things. I think it's exactly right. And I think there is a danger in a moment like this. I mean, this was scheduled sort of before the change of administration, but there is a danger in a moment like this to say the sky is falling. And, you've seen it in conversations emerging. Well, there is going to be resistance to all sorts of evils about to be wrought. And that's just the wrong attitude. I think the approach is it's a moment of that calls on public health to have clarity and sharpness of intention, to be clear about what we need to do, to be clear that we need to build trust, we need to be show to be competent, we need to show that we are in it for values that people care about. We need to build the political will behind what we want to do in public health. And we do it in a way that listens and is open to ideas, but also with sharp clarity about things that matter, to be able to speak about them when they are threatened. That last sentence I said, which I suspect most people in this room would agree with, is easier said than done. Because to come back to the ER metaphor, which is what Georgia started us with, when you're in the ER and there's an acute emergency, it's very easy to lose your head. But what a good ER doc does is she never loses her head, ever. And it is on us in public health not to lose our head, particularly now. I have argued, I realize this is not a universal perspective in the public health community, that we lost our head a little bit during COVID. And I don't want to see us do that again.
Yeah, I've certainly seen some of us preemptively lose our head in anticipation of losing our head. We've started to do that now ahead of time. So definitely it's a good message to send our community is that we need to be cool about some of the things that are going to be facing our profession, and not to be tempted to be drawn in and spar with everything that's said, but to continue to combat with science, values, a solid set of information. What's the response that as people start to be tempted to spark? Because that's become our social media world, where there's a provocative comment put out and the expectation that we suddenly have a statement about it. How do you react to that?
Yeah, well, I tell my staff when we put out press releases, we're putting them out for a reason. We always ask ourselves, what is the outcome we're hoping to achieve by making this statement? And we do that all the time. And sometimes it is in order to be, for be on the record. But most of the time it is for a very, very specific outcome that we hope to achieve. And, we also try to be balanced, in meaning that we look for opportunities. Sometimes we have to go out of our way, by the way, to look for opportunities to praise people. I learned something in my early management experience, was that 1 minute praise gets you a long way in an organization. If you can just find people doing something right, then you champion what they did right. And that makes it easier when they've done something you disagree with, to disagree with them. And then, of course, do it in a manner in which you're disagreeing, but not being disagreeable as part of that process.
Yeah, just to echo one aspect of what George said, which I agree with tremendously, is always asking ourselves the very simple question, which is, what are we trying to achieve? Before we say something or do something, what are we trying to achieve? And when one pushes that test on oneself, one realizes that sometimes the right thing to say is not X, but Y. Sometimes the right thing to say is neither X nor Y, but nothing at all. Now, when one has to be clear about trying to achieve, as George has said correctly, sometimes what one is trying to achieve is to put something on the record and to say it, even if it sounds outrageous, even if it's unpopular, that's fine. But most of the time, when we're saying things or doing things, we're trying to achieve real change. And sometimes, or perhaps most of the time, achieving real change is not by saying that thing we want to say, but saying a different thing to allow us to achieve change. So I would challenge us all to apply the simple test of what are we trying to achieve as a filter between anything we want to say and anything we're intending to do. And I think if we did that, we would be more successful.
Oh, great advice. Great advice. Taking that moment and not giving in to the tendency to suddenly respond and suddenly sound like we're right, could do us all some good. Yeah, this question comes in with something related that appeared in the chat. Do you think our culture of individualism works against us in some ways when it comes around trust and science? That if you have universal health insurance, for example, are you more likely to trust that system? If you have a greater sense of community versus the individual rights, or if you get a public health recommendation, sometimes that's viewed as an infringement upon your right to make a personal choice, even though it may benefit you and everyone around you. Do you think that culture or society somehow stacks the cards against us in that way? And then how do we address that part?
I think it's a false choice between individualism and community. And I think I think that premise is a false choice, that we are somehow separated into folks that believe we should bring ourselves up by our bootstraps and everybody else can, do it on their own. Because every time something bad happens, the folks in the church come out to take care of their loved ones, their parishioners. When there's a disaster in the community, communities bond together. I think the issue is how they see the need for community versus how they see the need for individualism on a particular issue. And I think our challenge in public health is to broaden people's view on the need for community engagement for things that people might think that if that person just got a job, their world would be different. And to the extent that we can help them understand that while for some people that might be true, there's a lot of people for which that is not true, and that the solution is community engagement in order to make that happen. And in fact, if you strengthen community, then you're also more likely to grab that person who is less likely to do the thing, that they need to do from an individual perspective, because you've changed those community values and they now feel the need to be a part of that.
I'm heeding my own advice in terms of what we're trying to achieve. I actually have nothing to achieve by adding to that, because George's answer is perfect. So I'm going to say nothing. I'm just going to underscore George's answer.
Fantastic. Wow. Very good. So something I want to bring up that both of you have mentioned tangentially and directly, in the sense of public health is about everyone. Not half the population. We're growing our tent. We want to make it bigger. A lot of times we frame that as equity. And we talk about health equity as including everyone, and that everyone gets better, everyone benefits from public health, good, strong public health science, strong public health recommendations. In the last couple of years, we've seen this backlash against DEI, and that's getting conflated with this idea of equity, so that whenever we talk about equity, there's some notion out there that people are getting ahead in a way that maybe seems unfair. And if anything riles people up is their own sense of fairness, right? So how do we address those concerns? Equity, we agree on in public health, is one of our core values, and we've all said it this morning in using slightly different terms. How do we address this as it gets caught up in the backlash against the broader umbrella of DEI?
Yeah, I mean, I can start it. I think, like many things in the past decade, there has been a social construction of a simulacrum of a much more complex and important issue. And that social construction is this notion of sort of a overweening DEI enterprises that impose on organizations and societies unappealing identity-driven simple solutions when we should be thinking much harder. But that's not the truth. The truth is that the principle of equity and the principle that none of us would like to be born into a country where sheer random lottery of where we are born or random lottery of color of skin that has absolutely no biological significance to our health whatsoever determines our health. That is a universal. And the notion that we should make sure that there are no structural reasons that keep some people back just by sheer accident of their birth is accepted and embraced by the vast, vast majority of people in this country. So there has been, DEI efforts which were intended to solve a problem that is widely acknowledged and embraced by Americans have become the target of attacks because they are seen as representing something that is undesirable. So I don't think that the sound and fury about this notion of DEI efforts as harmful has much substance. I think fundamentally it is on us to be consistent and persistent in saying that we aspire to a world of equitable opportunity and chances, of equitable access to healthcare, of equitable health for everybody. That is a core value for what we do. And we need structures and systems to achieve that. And I'm willing to compromise on the name of the program. I don't feel strongly about calling the program DEI or DIB or DIJ or DIA or JEDI. I don't feel strongly about that. I do feel strongly about the importance of having systems and structures in place in organizations, and organizations small and large, all the way to national, to make sure that we have equity of opportunity to live a healthy, rich life for everybody.
Yeah, I'll build on that. And we've allowed people to redefine DEI to something that it isn't, by making it defined as exclusive. And it's not exclusive. It was always meant to be an inclusive term. And if we have to change it to IED, so it's inclusion, equity, and diversity, okay. But I think the principles are still there. But I also mean that we have to make sure we are articulating it in the holistic way that we intend it. So we have to talk about DEI in the context of not just racial equity, but gender equity, rural urban equity, equity between communities of the same race. I've looked at lots of rankings of states, for example. If you look at rankings of county, you look at the county health rankings, and you look at in states which are predominantly white states, and you look at counties that are juxtaposed to one another, and you still see 2 to 3 year life expectancy differences between those two counties. You have to articulate that so that you take the race thing off the table, and then you can have that conversation. But you have to do that with some intention so that people see that you're talking about all of these various areas in which there are disparities and that the solutions are universal. Making sure that people have a livable income, making sure they're not exposed to toxins in their environment, making sure they have equitable access to safe, affordable foods, good education, and on and on and on. All of the social determinants that we know fundamentally impact your health, the 80% of things that occur outside the doctor's office that empower you or disempower you to be healthy. But we also have to do that with intention. and make sure that everybody sees themselves in that. And I think that is something we have failed to do, is make sure that everybody sees themselves in the tent. And so reversing the initials, going in there, telling them what we really think, and not allowing them to accept redefining those terms, I think is important for us to do.
Yeah. Fair statements, all of that. I want to bring a question from the chat in, which is, please address how we're about to lose Black doctors due to misguided rulings against quota systems for medical schools.
Yeah, the affirmative action programs have been misunderstood for years. And, you know, I'm always fascinated when people tell me they can't find any. I always say you didn't look hard enough. And most of the affirmative action programs, what they fundamentally really did was they went and looked for people who were qualified to participate in the competition to go to med school. That's what they really did. And they went and found low-income individuals of color, low-income whites. They went and found underrepresented people in a variety of disciplines to give them the opportunity to compete to get into medical school. And I think that, quite frankly, I wish the medical schools would hold their ground and just fight those things in the court and not allow people to redefine those things. Because the truth of the matter is, the tail to get somebody through STEM education, it's a big STEM. Now, you also have to recognize that there are some other societal things that are limiting the number of African-American physicians in particular going into medical school. And that is the number of diversion programs that we have. Those diversion programs mean catching kids and sending them to jail. Kids that are going from the school to prison pipeline. So we have to also fix those diversion programs so that the pool of individuals eligible to get into these higher education programs is increased. And then, of course, giving them the opportunity so you have more first generation students that get to go to school. And then finally, and this is for all students, we need to make the cost of medical education much cheaper. In fact, the cost of health education much cheaper, because the truth of the matter is nobody's going to be able to afford them. It's gotten way too expensive. It's out of control.
Yeah, I have little to add to that. I didn't say that, there's a good literature about the structural constraints on people who come from backgrounds where they have fewer assets, be those financial assets, physical assets, social assets, and them finding their way towards medicine, particularly towards specialties, and that the system sort of is set up so that there is a clear impediment to those who come from a few lower asset backgrounds to to getting into the higher level of clinical care. And those fundamentally are what need to change. The exportation and the pipeline programs are part of it, but fundamentally, these are structural challenges.
Yeah.
The other thing is, and I'm a proponent for legacy programs. I don't personally think we should get rid of the legacy programs. And what I mean by that is we now have second and third generation, sometimes first generation physicians that have gotten into school. And now they want their kids to go into school behind them. And they often got preference because they went to that medical school or they went to that university. Quite frankly, the really well-to-do, they're going to get in no matter what. Mommy's always going to buy a new building. They're going to get in. The challenge is, how do you address those kids who have worked hard and their parents are already in the field? It's been that way for plumbers and electricians, people in the entertainment industry, and all of a sudden we're now going to shut the door for those legacy programs for people in the professions. I think we need to rethink that. Now, it needs to be fair. We need to find fair ways to do that. But the fact that someone's family member went to a school creates a family history and a sense of belonging that I think actually aids that individual in achieving success and more likelihood they're going to graduate because their parent went to that school.
Yeah, well put. I have not heard it articulated that way. Yeah, very interesting.
Yeah, and you know, I mean, look, there are multiple layers of this problem. That it is a problem that so much of the opportunity for leadership in this country is funneled through schools where fewer than 6% of students end up going. That is a structural problem. It is even more of a problem that a lot of those opportunities to actually be a part of those schools is reserved for legacy and for non-academic achievement. It is even more of a problem that then in the other half of the opportunities to participate in those schools requires layer upon layer of advantage to even be able to compete to get those schools. So these are all structural challenges, and I feel like the public conversation has been very superficial about this. And but then again, it is on conversations like this one, hosted by the Institute for Science and Policy, to articulate how complicated these issues are, but also how important that they are tackled.
Yeah. Going back to the earlier question I asked about our society being more individualistic oriented than community oriented. Sandro, you made a statement that we're willing to live with the fact that so many people in this country, by virtue of where they're born, literally, it's okay that they are not provided the same opportunity, the same access to health. That's a direct conflict with everything public health is about. And that's one of our biggest challenges. How do we start to break that down?
Yeah, I think this is perhaps the hopeful side of me. I don't think we are okay with that. I think we, and by we mean society at large. I think we, society at large, capital we, do not understand that that is a political decision. We do not understand that these are political decisions that we are making that create systematic barriers to some of us to achieve what all of us consider to be fundamental birthrights, which is the opportunity to be equally healthy as one another, not determined randomly by where we're born. You know, one can get philosophical about this and talk about Rawlsian experiments that says, what kind of world do you want to be born in? You know, behind a veil, if you don't know where you're going to stand on the health scale, you're going to choose a world where everybody is actually healthy. And I think fundamentally that has deep, profound appeal. But the reason we, and use the capital W we, I mean all of society, accept that is because we don't understand that that is changeable. Now, we, little w we, in public health, understand that. And if we do not communicate that, then I think it is our shortcoming. I mean, my challenge often to public health audiences is, well, if we in public health do not communicate that, who else, whose job it is? You know, whose job is it? Before COVID, leaving COVID aside completely, American life expectancy had dropped year on year for 3 years in a row. And first time that had happened, turns out, since the 1918 flu pandemic. And I would often sort of find myself in public health audiences where it's like, well, there's opposition, there is a spirit of individualism, Americans don't believe in this and that. And my challenge to public health was always, well, whose job is it but ours to change that? It is our job to change that. So I think, Cathy, this notion is accepted in broader American society because it is not understood that it is a matter of political will to change that. And I think it is on us to communicate that.
Well, I'll tell a story. I remember being the health commissioner in DC. And the Queen of England I've told this story before, the Queen of England came to DC and made a royal visit. And then, of course, it was later that it was time for the obligatory trip for some of the lower income community kids to go to London. And those kids were excited, you know, and I happened to be in the office of the chair of the health committee of the city council, and some of these kids were in his office, and they went off to lunch, and we started talking, and I was, articulating what a wonderful trip I thought these kids were going to have. Actually, I was trying to figure out how to get myself invited for the trip. But I was talking about, oh, they're going to see, the Queen, they're going to see Buckingham Palace, they're going to see this, they're going to see that. All the things that I had aspired to see in Britain. And all of a sudden I realized I was having a one-way conversation with the chair of the council of this committee. And I said, okay, what am I missing? And he said, you don't get it, do you? And of course I didn't. And he explained to me that these kids were not excited about going to London. So Washington, D.C. is a city 10 square miles. These young people live in Ward 7 and 8, which was east of the river, the Potomac River in the city. It's the most impoverished part of town. And from where they live, National Airport, which many of you know have been in D.C., is right outside the city. I mean, right, literally less than a mile away from where they live. But all they see from their house is a plane coming over the horizon when the planes take off. So in a city 10 square miles, these kids have never been to the airport. They had no concept of what an airport was or getting on an airplane. So they were excited about going to the airport as their experience. Now, as we understood, once they got to London, they were going to have a great time, and they bring that experience home. But the point I'm making is the hopelessness and helplessness that we've built into our society, where we have people who really don't have any experience living outside a small area. And when you go talk to those kids, most of those kids don't think they're going to live to be adults because of the problems that they have in those communities. And so from their perspective, they're going to live a full life. They're living like someone with a terminal disease. They're going to buy gold chains. They're going to get pregnant. They're going to risk HIV/AIDS because they're never going to live long enough to get AIDS, for it to express at least. And so they understand that. They're better epidemiologists than we are. And so we have got to make sure that we help build these communities and the people in these communities so there's less hopelessness in those communities. And by the way, I'm talking about these kids in DC. That's the same for rural America, the Appalachians, rural Mississippi, Hispanic communities, and many of our communities in southwest, part of the state, where we have not invested in those communities in a way to give these folks a future, so that they see they're part of something going forward. And I think public health plays an enormous role in that happening. And I think that's our central challenge. By the way, over the next 4 years, that's absolutely our central challenge, making those folks feel part of the collective.
I couldn't agree more. I have nothing to add.
Yeah, absolutely. It's, by public health, touching every part of our society and every part of that system, we have such a responsibility to change that tide. I want to make sure I bring up one of the questions that's come into the chat before we start to head to wrapping things up. One is about maternal mortality, and should it be a policy priority, or rather, why isn't it? And speaks to that the United States ranks poorly in maternal mortality. And related, there are lots of places where the United States is just simply falling behind other Western countries in terms of major markers of health. How is it? Where should we prioritize?
Yeah, we've done this a lot. I remember the Bush administration doing the Healthy Families Initiative. There have been so many maternal child health initiatives in our nation, and yet we continue to fall far behind. And, let me just start by saying a third of our counties in this country don't have access to reproductive health care. A third of the counties in our country. And I think that's the problem. And I'm not talking about abortion per se. I'm talking about any type of OBGYN services, provide reproductive health services to those women with the clinician that can provide those care. And then, we're not paying attention in our delivery systems. We just haven't focused enough on either the acute care side of this or the prevention side of this. And yeah, it's a crisis, and it's a crisis that's growing. And then you add on that the most recent Dobbs decision, which has exacerbated at least even the acute care part of reproductive health care. That's a problem. And we're going to have to address that. We're going to have to address that soon, because those are lifelong problems, for those children that are born and are born with a range of reproductive challenge, birth challenges, disabilities. The fact that we're losing maternity is now becoming a death sentence for women. We have to fix that.
Yeah, I'm always a little bit uncertain how to address the what is the priority question, because I actually do think there are a lot of things that are important, and I think different outcomes are differently important to different people. So I feel like perhaps a better approach is to lay out the spectrum of challenges that face health, and to say that our work on any and all of these is important, and that we should act pragmatically where we can make a difference on any number of these areas. I think that ranges from what George just mentioned, to the ongoing threat of pandemics and infectious diseases, to the many downstream consequences of climate change, to the unconscionable gaps in health achievement between groups as marked by racial, socioeconomic, educational status, to the mental health challenges that are increasingly recognized as a real concern, particularly by younger generations, and that, by the way, fall disproportionately on people with fewer assets and lower socioeconomic position. So I think all of these are critical to the health of the nation, not to even begin talking about globally, because that's something else which we could talk about. And I think they should all be in the in the vision of public health, and to say where are opportunities. The last election was a really interesting exemplar of this, where we saw, in the same breath as we saw a Republican Party brought back to power after 4 years, we also saw a number of state level votes that actually were very clear endorsement of positions that are in direct contrast with Republican Party positions. So I think that showed the opportunity there is to act in particular areas to advance the goals of public health. And I think we need to be principled, but also pragmatic.
Yeah. I'd like to turn the conversation now, as we're starting to end our time together, to think about what it is you're optimistic about. What are you excited about that's for public health going forward? We deal with such serious issues. We ask people to look at some things and face some things they don't want to face. And then at a very practical level, I knew someone who worked for a public health department, and she characterized the problem with public health as we take the fun out of life, in a very simple sort of way, around telling people what not to do. This is now an opportunity for us to kind of reframe some of that, right? And to think about, what is it we're excited about? How do we start putting the excitement, the things that we do, in the most positive light? And that would make people excited about public health, because I think that's an important part of the message too.
Public health is a story of success and triumph. I mean, the sentinel achievement in human history was the doubling of life expectancy over the past 150 years. I mean, nothing else compares to going life expectancy globally expected to be 40 to now we expect to be 80 in high-income countries. It is extraordinary. That is the triumph of public health. It is a healthier and better time to be alive than any time in human history, despite setbacks. There is no question about that. And public health needs to be better at leaning into its role as creating freedoms. And I do mean freedom. It's freedom from unnecessary disease and disability. We should not be put in the box of being against freedoms. Remember, a lot of the agenda of public health is predicated on a health and human rights framework. Human rights, the central tenet of human rights is individual autonomy. Individual autonomy means freedom. So I think we have allowed the narrative to be sidetracked from fundamentally public health should be about joy, about bringing opportunities for everybody to live rich, satisfying, full lives. We should be about joy, not the opposite.
Yeah, I would agree. You know, we often get so much bogged down in trying to solve the problems that we don't spend the time to talk about our triumphs and tell our own story. You know, far too often the story is about we have to boil our water today, or you have to wear a mask because there's a wildfire, instead of telling people, boy, you know, of the last 20 days, nobody fell, nobody got injured, nobody got sick in a restaurant. We've got to tell our own story, and we have allowed, tragically, the narrative to be told by others. And I think we have to tell our own story, and we have to change that narrative. And we also have to make sure that people understand that public health is both a best buy and a top national value. And that story of the doubling of life expectancy and how that happened and why that happened, that's been lost to history. Only we know that story. And I think we have to do more to tell that story. By the way, the medical care people do that all the time. You know, we gave these people this drug and we have cured XY disease. We can make you better by changing your hip and putting these stuff in your hips and in your hearts. And people love those stories. We don't get out and champion ourselves as much as we need to.
You can get into your car and not unduly worried about dying every time you get into your car, because we have created safer cars, safer roads. We have rules against drunk driving. You can actually eat food without worrying about getting sick. You can actually breathe the air without worrying about it giving you bronchitis or exacerbating your asthma. You have laws that mean that you can go to work without worrying about being injured and incurring a lifelong disability at any moment's notice. These are the conditions that we live in. These are freedom from unnecessary disease, and that is what public health has created. And I think George's point about making the point about Best Buy is a critical point. So, Cathy, I think to your question, we just need to be better at telling the story, and perhaps having this conversation as part of seeding, getting better at telling the story.
I think so. That was certainly one of the objectives here, to think about it. And I'll share with you some thoughts I have around opportunities ahead. One, I think we're going to start talking about public health in a way that we've never talked about before, because people are going to bring up things about vaccines. They're going to talk about preservatives and foods that they've taken for granted. I actually think it's going to take center stage in a way that it hasn't taken in the past. In many cases, we've taken public health for granted. We get in the car, we put the seatbelt on. Now, I think things that we just assume were taken for granted or proven science, settled science, I think we're going to have a chance to start talking about it again. And this is an opportunity for us as a field to start thinking about how we're going to do that, because this will be an opportunity that we haven't had in the past to talk about public health at the dinner table, talk about it with our neighbors. And so to really embrace that opportunity, because with some of the appointees who really do like to be in front of a camera and talk about things that we might otherwise just instantly disagree with, we're now going to be able to enter into a thoughtful conversation and to bring a baseline to a place where we haven't had it before. So that is one of the things that I'm actually excited to have the opportunity to do. The other thing is around technology and the opportunity for us to get better, to embrace these new technological methods so that public health really becomes a much better science, and a science that is on par with other sciences across the board. And then I think now, and you have both said this in so many ways about our chance to communicate and to communicate in a way that people can understand. So we'll be given that opportunity. We have the opportunity now to be even better than we have been before. And we understand the importance of communicating and not just assuming people will be, of course, need to get a vaccine. So as we then close out, what are some things you would like the audience take a few moments, reflect on this conversation? What would you like the audience to take away?
Let me start by just saying, so first of all, our future is bright. I think that we have an enormous opportunity to move our nation forward. We're coming out of a pandemic. It been a tough 4 years. There's no doubt about these last 4 years have been tough. But we have an opportunity to move the nation forward in ways that I think others have not recognized. And I think there's an opportunity for public health to, first of all, say we are the nation's chief health strategist. So we need to own that. That's our job, to be the nation's chief health strategist. Whether you run a health department, whether you're at a nonprofit organization, we ought to make sure that we're going to be the voice of reason, the adults in the room, using the best evidence and best science that we know. But I think the other thing we ought to do is make sure that we redefine ourselves in the minds of the public as we are the best listeners in the community. We're here to listen to you, and we're here to work with you to achieve optimal health. And if we can achieve those three things, we're the chief health strategists, we're thinking about it every day, and we're here to listen to you and help you achieve your goals, I think we'll be most successful.
Yeah, I think that's right. I mean, I think the future is bright. I really love how, Georges, you led with that. It is an important time for public health. It is a time of, look, it's been a rough, George said it's been a rough 4 years. I think it's been a rough 10 years. And I think the reason I say 10 years is because I do think that the simultaneous rise of social media and the rise of populist political approaches that drive wedges in populations, which roughly was started 10 years ago, really threatened the fabric that public health needs to do its work, which is a fabric of collectivity. And I think it's taken us that long to learn this, to see this clearly. But I think we have, and I think it is a pivot moment where we are reimagining public health, reimagining what to say, reimagining how to communicate. And part of that is leaning into the positive. This is a healthier, not only do we want to be the healthiest nation in one generation, to use what George's organization pushes so effectively for, but say we want to be healthier tomorrow, and public health is going to make that possible. And we want to create a big tent to do that with due vigilance for potential threats, but ultimately leaning more into opportunities. So I think this is a really interesting and important moment for public health.
You're muted, Cathy.
I think you're muted, Cathy.
So sorry. Georges, did you want to add anything to that?
No, I just think, to the extent that we can be part of helping to re-achieve societal cohesion, we need to do that.
Yeah. And it looks like one of our audience members is going to take an opportunity to supply you with some personal stories that I think will be useful for all of us to be part of the stories that we tell that are powerful, so that we can do some of the things that we've seen the medical science world do incredibly effectively going forward. And I do resonate with it. This is an exciting time for us. This is a time to be very, very optimistic. We're actually being handed an opportunity you can't tell your good breaks from your bad ones. Unfortunately, I mean, in life. And this may be our opportunity to take a step forward in educating those around us to embrace the community, let public health go back out and be infused across the community and accepted as a friend, not a foe, so that everyone does have the opportunity. And we have a nice comment and a thank you on Hardened by the Professional and Positive Approach. We don't have a tendency to say enough of that ahead of time, to give kind of that sensible way of taking our own pulse first. Any final thoughts from our audience in terms of what you would like to put before the panel?
Let me just say a week or so ago on the 25th was Public Health Thank You Day. And so I just want to take the opportunity to thank our public health workers for the extraordinary work that you do and your leadership. And we here at the American Public Health Association salute you and everything that you do. And so I thank you. And of course, to my good friend and colleague, Dr. Galea, and you, Dean Bradley, thank you for the opportunity to be here today.
I will simply echo that. It is, first of all, it's a privilege to be here. I want to thank the Institute for inviting us, and Cathy for your moderation, and George, as always, for the privilege of conversation. But I actually think it's conversations like this that's filled with hope, because I actually think it is how one shifts the conversation. I do believe in the importance of these conversations, and I think it's a conversation of 3 people with 50 people in the room, another 50 people in the room, another 50 people in the room. That is how we change how we think collectively. And the world is better than it used to be, and it will be better again in the coming decade. And I think there is a pivot point now. It's a moment that's making a lot of us pause and reflect, and that's okay. That's a good thing.
Agree. And I appreciate you both for the insight that you brought, the perspective, bringing us back to the stories and the communication and understanding that it's not all over, that this is an opportunity for us and how we move forward. So I think that's a great place to close out. Thank you both, and to bring Kristen back to us.
I'm actually going to jump in for Kristen. I'm Trisha Waddell with the Institute. I just want to thank everyone for the wonderful conversation today. Thank you so much. We really enjoyed it. And please stay tuned for our next session starting at 2 o'clock, climate policy. Thank you again for just all your wonderful insights and information today.
Fantastic. Thanks. Bye-bye.